We are at 6 o'clock. So it's wonderful to see so many familiar faces and new faces, and to all be together in these really challenging times that we're facing. This is the SUMHI Action Update. We do these about 2 times a year, sometimes a little more, sometimes a little less, with the goal of really updating us on some of the activities that are happening at Dartmouth-Hitchcock to address challenges of substance use disorder and optimize our treatment of patients, and also to really bring us together and engage with other health systems, other individuals within Dartmouth-Hitchcock, and with our communities around some of these issues. Today, of course, because we have moved into this really challenging pandemic, we're going to focus some of our discussion on how to best treat people with substance use disorders and provide care in the context of COVID. So my name is Seddon Savage. I am going to be helping to facilitate today. Sally Kraft and Will Torrier here, and they are the leaders of the Substance Use and Mental Health Initiative at Dartmouth-Hitchcock, and I wanted to invite them to say some words of welcome and comments to start us off. Sally or Will?
Thanks. Can you hear me?
Yes.
Okay. So, first of all, it is kind of fun to see everyone on this big gallery spread. But I really wanted to thank you all for being here for this update, and for you, Seddon, for organizing this get-together. But we gives us a chance to, as a community, continue this work and keep moving it forward despite the COVID challenges that our whole world is facing right now. It's no surprise to anyone who's here that people are still suffering and dying from their substance use disorders as this other epidemic and pandemic is going on. So the work that we're doing, trying to continue it, trying to sort out how to provide care in this environment is incredibly important. And so I'm really glad to be here, hearing and learning from you and sharing what we know and our drive to continue this work. So thank you all very much.
Thank you, Will.
And I'll just echo what Will said. Our thanks to all of you. I think, it was only 2 or 3 months ago that we were dealing with another epidemic, and that was the opioid epidemic in northern New England, and how quickly things have changed in just a matter of days and weeks. The hard part is still to come. We're going to be even more consumed with planning, and then actually the care for the ever increasing numbers of patients who will be ill with COVID-19. And what I'm really hoping is that through the course of our time together this evening, that we can think very purposely about our very, very vulnerable populations in our communities, as the entire health system, in fact, the entire sort of fabric of our communities gets rocked by COVID-19. And I think that that's what we can gather here tonight, is say all the work that we've done, how do we make sure that we can protect those who are most vulnerable amongst us. So thank you for all your work, and thank you for all the efforts that are going to be coming in the next couple of weeks.
I guess just finally, if there's anything we can also learn during this time that's transforming care so much that we can apply going forward, it would be great to, if we can not waste this crisis in terms of learning that might help us with our addiction work as we move forward too. So.
Absolutely, thank you. So I'm going to attempt to show my screen. Bear with us with the technology. This is the first time we've done this large group sharing. Can everyone see my screen now? Yes? Okay.
Yes.
So just some requests and housekeeping really. If each person could please chat us, send a chat message now with your name, your department at DH, or your organization, if you're with another organization, and your email address. We'd really appreciate it. So we'll know who's attended and we can send out any other follow-up information. You'll be on a group mute, but you have the ability to unmute yourselves to speak. We're asking that people submit questions as we go along or comments around the individual presentations. And then at the end, we'll come back to those questions. We were going to try and take questions after each brief presentation, but thought it would be a little unwieldy, or could be, trying to use this technology for the first time. So we'll have our discussion at the end, but we'll gather your questions and comments as we go along. And then we'll ask you to unmute when we recognize the question, and you can ask it in person. All the slides will be posted at the SUMHI website after the presentation. So any information you want to go back to will be there, and we'll send that link to you in the next couple of days. Presentations will be a maximum of 8 minutes. Some may be shorter than that. You'll hear a little chime speakers at the 7-minute mark. Laura, can you do the chime? If not, we.
I can.
Okay. Okay, it's subtle, but there. I have to show the obligatory CME form. We did not pre-announce CME, but if you are physicians or nurses looking for general credits, this is certified for 1.5 hours of Category 1 AMA credit. None of the speakers have any conflicts to disclose. These are the number to which you test that code if you're already in the system. If you're not, come back and look at this slide when we post it, and you can get help at hitchcock.org around getting CME. So before we start with the formal presentations, I wanted to make a few comments about regional context. I have been fortunate to work with the state on some of these issues over the last few years, and have gotten a real respect for some of the very rich and complex systems around the state, and wanted to mention them because I think the more we can liaise with each other through existing systems, the more valuable it is. But first, to look at some data. This came out about 1 month ago, 1 month and a few days ago, and it was the final report on 2019 opioid overdose deaths. So as Sally said, we all know that we were in the middle of an opioid epidemic, and look, we were just beginning to make some progress through much of the work that many people on this call were engaged in, beginning to see a bit of a change, whether it was all due to Narcan or we're really seeing patterns in drug use and getting people into treatment. I hope it was the latter. But we've begun to make inroads into that epidemic really across the country. Unfortunately, as we all know, here we are 1 month later, and these are yesterday's data from the Department of Health and Human Services in New Hampshire, with 258 people confirmed to have COVID, 3 deaths attributed to it, which is about the national 1%, and hospitalization rates of 15%, with 1,000 people being monitored in the state for possible COVID. Unfortunately, when we look at the expected trends, now there are many modeling systems, as you all know. We're just about here at this dot right there. And we can see that we're either going to go up a little or we're going to go up a huge amount. But we know that the surge is coming. So as Sally noted, we have this problem that's still strong of substance use disorders that are injuring people and causing death, as well as the new COVID epidemic. We know that our populations of persons with substance use disorders and mental health disorders are particularly vulnerable at this time. So some of the networks I think most of us are familiar with are wonderfully distributed regionally with regional NIDASs throughout the state and central supports. So the public health networks, we know there are 13 regional sites, bring people together against diverse sectors. And I just wanted to point out that 2 of their cardinal charges are to address substance use care and prevention and to respond to public emergencies, public health emergencies, such as epidemics, as we're seeing here. So they are well positioned to help us work at the regional level. We know and they've been around for many years now. The integrated delivery networks, the IDNs, have been around for about 3 years with the goal of preparing us to treat both physical and mental health in an integrated manner and to address the social determinants of health. There are other sub-goals that different regions have, but they bring people together across the community, physical and mental health providers as well. And so they have created a fabric with which we can interact. Luke Archibald is going to talk to us about the New Hampshire doorways, but again, a very rich network of health providers aimed at being the doorway into treatment, the entry point into treatment for substance use disorders with referral to community-based supports. Those of us in the healthcare field don't necessarily often think about other professionals who are really addressing these issues. But I just wanted to point out that our whole justice system is pivoting to address substance use disorders. We have 10 drug courts in the state, 10 mental health courts separately, who divert people to treatment over incarceration for crimes using incentives and sanctions with a goal of reducing recidivism. EMS, local law enforcement, state police, and others have many projects aimed at reducing substance-related harm and now helping get people into treatment beyond their usual roles of acute care. But they are duly challenged now because they will be the first responders also for COVID. So I just wanted to note the contributions that they've made both in substance use disorders and around COVID. Very importantly, for this epidemic, we also have a network of New Hampshire recovery community organizations with a facilitating hub at Harvard Homes, but we have 15 recovery community organizations around the state that do recovery coaching, run groups, wellness activities, connect people to treatment when it's needed, and all of them have robustly transitioned to online care during the COVID epidemic. And there's a website there if you wanted to link and see what some of them are doing. It's very impressive, some of the efforts that are being made. So I mentioned all these networks. I wanted to mention that the Bureau of Drug and Alcohol Services at DHHS really coordinates and provides expert input into really all these networks. They serve as consultants and coordinators for all of this and organizing the state system. Governor's Commission on Alcohol and Other Drugs brings together 26 commissioners from different fields to think about these problems, create a state plan that informs some of the work of the Bureau of Drug and Alcohol Service and others. But the relevance of understanding these networks, I think, to all of our work is to think about partnerships on the local and regional level, to think about facilitating some of the work that we've done, which may be models through some of these networks, and to distribute our work products thoughtfully when we create them. Often, I think there's a risk of duplicating efforts, and just wanting us all to be aware of how much is already being done in the state and what the networks are that we can use. The final thing I wanted to say before our formal presentations was just to let you know that SUMHI has a COVID-19 page. We are trying to pull together all the resources we can on federal and state policies, on clinical and patient support materials. We're adding every day to it, and so if you have things to send us, please do, because we want to make this a useful site for everyone during this time, specifically related to substance use disorders, mental health issues, and COVID-19. So we're going to start. Matt Duncan is going to share with us efforts at DH to integrate behavioral health and primary care across the system. Matt's a psychiatrist who's really leading these efforts, beginning in Nashua and now spreading along to other parts of the DH system. So I will unshare, and Matt, if you can share your screen.
All right, is everyone able to see that?
Yep.
Great. All right, thank you, Seddon. And this part that I'm going to present will really focus on the collaborative care programming that is mostly looking at the mental health conditions. I'm not including much of our alcohol and opiate as Charlie's presenting as well, but I think as everyone knows that our model is a combined mental health and substance use model, but not seeing that substance use piece included richly in here is just to allow Laura and Charlie to be able to present that part. I think most people are aware that this collaborative care model is one of the initial SUMHI initiatives that came out of the identified need in primary care across the DHH system. And mainly what I want to present today is just an update on our sites, our team, and some of the data that we're gathering just to give people an overview of where we are. This is just a list of our current providers. And I think one thing about this program is that it relies very, very heavily on a skilled and also scarce workforce. This model, as you see here on the right, which is from the collaborative care model out of University of Washington, this requires a behavioral health clinician, and programs can use different types of people. We've chosen from the outset to use licensed clinical social workers and licensed clinical mental health counselors, and we've been very, very lucky to be able to recruit and onboard the group that you see here. I will say that for the better part of a couple of years, we've still had open positions that we're not able to fill. We're not quite yet up to what we would hope would be our baseline staffing. But we're very grateful to have this group here. And just to put some faces with some names, so some people know some of these folks. This is not our complete group, but in the back row, starting from the left to right, we have Jacob, who's in Manchester, Laura, who is in Lebanon, Eric in Concord, Anne in Concord, Allison in Manchester, and then to the front row, this is a little bit of an older photo. Nancy is now transitioned over to our ATP program. In the center is Joanne Fideli Wagner, who's our behavioral health clinician manager and has been very instrumental in all this work. And Amanda Toddy there at the very front right is our behavioral health clinician in Nashua, who really launched our pilot program. And those that are not shown there are Sue Poland, who's been our longest standing pediatric person who's in Lebanon, Deb Hansen, who's another pediatric provider down in Manchester, Bedford, Sarah in Nashua, Shanna, a new pediatric person in Concord, and Sophie, who has filled Nancy's position here in Lebanon. So remarkable group of clinicians that are in all of our primary care practices in Lebanon and the community group practices and doing just a tremendous job. This is some data that we've been able to start to pull. This is looking at this past calendar year. And what it's showing is the rates of our screening. So part of this program has been setting up automated screening through MyDH and at the kiosks, the interfaces with the electronic system. You'll see here that over this calendar year, 28,000 plus screened encounters have been available. Our completion rate across the board is between the kind of low 70s up to mid 80s low 80s for substance use. So we feel like that's pretty good, stable penetrance, but we're going to be looking to see how we can close that gap a little bit. And so these are the rates for depression, our screening rates for anxiety, and for substance use. And then this is just a P chart to show that overall the process looks fairly stable. We're not seeing any strange variation at this point. So that's all very good news. And I want to give significant credit to Joe Bond. Joe is a leadership and preventive medicine resident who's been helping us this year, particularly with our Concord site and helping with some of our data here. From the screening process, patients are brought into care with our behavioral health clinicians that are teamed in primary care. And this just shows a general sample of what happens to these patients. And so over the course of, through this January of this year, our behavioral health clinicians have actively engaged 2,265 patients. And this just shows the number that are currently active in the program, the percentage who have completed an episode of care. We are seeing about a 15–16% dropout rate. A very small number that get referred on to other psychiatric services. I think that's a credit to the screening process and the identification of our primary care providers. And then there's this portion who get referred, this 19%, but we're never able to really engage those folks, and then a kind of catch-all. But what we're seeing is that about 57% of patients complete that 12-week episode of care that really is the core collaborative care deliverable in primary care. And that can be a combination of on-site in-person visits, but largely is remote and telephonic work. And when we touch on the theme of COVID, we'll see that this model is already well positioned for our current environment without having to make tremendous adaptations because of the way we're set up. We're also now starting to pull some clinical outcomes. And this is looking at just one of our sites in Concord here. And this is some data on the depression scores of our population. And then this table are the anxiety scores using the GAD-7. And basically the summary message here is that for both of these conditions, we're seeing over the typical 12-week episode, on average, about a 50% reduction in both the PHQ-9 and the GAD-7 scores. And when people are ending care, on average, they're getting close to what would be defined as remission of those symptoms. So that's encouraging to see those patterns emerging. We do see a little bit of a difference between our two cohort groups as far as severity of scores, which we're looking into, but on average, we're seeing very similar results. One of our big challenges moving forward is that we want to make sure that these programs are sustainable. And part of the sustainability is being able to hopefully capture the new billing codes for collaborative care. And this is a dramatic shift for us as a program, but also as an institution. And we're deep into a process with Dartmouth-Hitchcock to evaluate these codes, make a final decision of whether we're going to move forward with these codes. And hopefully that decision will be made and we'll be able to have this be a more sustainable financial stream for our programming and our staff. There are some barriers to this work, which we're hopefully going to find ways to overcome. I'm pretty optimistic about it. And then in addition to the adult work, which has really benefited from the SUMHI program with project management and resources, we're now able to push forward with our pediatric program. We've had behavioral health clinicians in pediatric practices, but not with the same structure in project management. So as of October, we were able to formally launch this pediatric group. The pilot site will be at Manchester for this. And this group is off and running. The pediatric literature is not as robust, so we're having to really dig deep and adapt. We've drafted the charter. We've developed a much more broad screening inventory that applies to children, which is much more complex than on the adult side. And we're taking the adult work and doing process mapping and model definition, as well as developing some patient education resources along the way. And this group meets a couple times a month to try to move this work forward. And this is just an example of where we've taken the initial collaborative care model, the way we adapted it for the adult side, and then further adaptation for the pediatric side. So we don't need to spend a lot of time on this, but just to show you that the work's moving forward in pediatrics and leveraging the adult work, which is a big advantage. And then just Seddon asked us to comment on how our work is being impacted by COVID-19. So as of today, I can say that all of our staff at all sites are fully moved to remote work from home and have the technology and the support that they need to do that work. As I mentioned, the model, which already is highly reliant on telephone outreach and outside of the office work, is well poised to serve this population even while people are quarantining and social isolating. You'll just see here kind of the ratio in the program between the billed encounters of face-to-face work and the unbilled, which is already kind of now where everybody might be heading, or not unbilled, but this would be remote work as well. Happy to say that our groups are also engaging in how they can support the primary care teams psychologically during this time. None of our staff are out due to illness right now, which hopefully we can keep it that way. But all of them, like everyone else, are trying to do their best to balance their jobs, their childcare, their elder care, and trying to stay well. But feeling very proud of our team right now. So thank you, Seddon.
Thank you, Matt, so much. That's really impressive work. When we consider the baseline, how we had carved out mental health and SUD screening. So thank you for all that. Charlie Brackett is up next. Matt, if you can unshare your screen and Charlie share your screen. Charlie is an internal medicine physician who does primary care at DHMC, and he has been the medical leader for the OTSI team, which is the Opioid Addiction Treatment Collaborative, transforming care of people with opioid use disorders across our system.
Hi, and I was wondering, are people seeing presenter view or seeing my slides?
I think presenter view.
Maybe I should.
We see your slides, but we see a lot of them at once.
Okay, let me go into regular view here. Apologies.
It's okay. We could take presenter view if that's what's easiest. In the meantime, we can browse everybody's.
Just when I go to full presenter view, it gets rid of my margins, so I can't get back here. Okay, is that better?
It's just fine. We can see them.
Whatever. Does this still work? Oh, it still does work. Okay. So the goals of OTSI, the Opioid Addiction Treatment Collaborative, are to identify and encourage treatment of opioid use disorder in general medical settings. Really, we want to make this mainstream so that it's considered comparable to treating diabetes or depression and taken on by generalists in the emergency room, on the inpatient service, and in primary care. So the goals for the ED and inpatient are to initiate the treatment while patients are in the hospital, and then to have a concrete follow-up plan and enough medication to get to that plan. And then in primary care to give the holistic care, including mental health and medical conditions. And then to the bottom right, you see our goals were made a little more concrete by the system-wide quality and safety metric of doubling the number of buprenorphine starts on the inpatient and ED settings. So we've been reaching out to our 5 affiliate hospitals to try to make this happen. So in primary care, we have all sites prescribing, and we're building upon the collaborative care model that Matt just discussed, using a shared care model where where the prescribing primary care doc will alternate visits with the behavioral health clinician. We have a 4th Friday learning collaborative to support this endeavor, where the waivered PCPs and the BHCs come together. We just met last Friday to discuss the impact of coronavirus on our practice. Huna Kong out in Manchester is doing a grant to try to reduce the the progression of opioid use to opioid addiction. And then to touch upon our coronavirus response, pretty much parallels what we're doing in primary care in general. We're moving the large majority of our patients from in-person to phone and telehealth visits. We still have people in the clinic to do in-person visits every day from 8 to 8. And stress and isolation are causing increased relapse risk in our patients. So we're trying hard to avoid any lapses in buprenorphine, and have created a patient information smart phrase to get information about virtual mutual support meetings and apps and other supports out to our patients. And these are some data of how we've been doing over the last year, an increase in new starts in primary care. On the inpatient service, we've been screening all along and rolling that out to new locations. The BIT team is actively engaged in evaluating, counseling, and arranging follow-up for patients initiating on buprenorphine, and they write the bridge prescriptions to get people through to primary care or specialty care follow-up. There's a recovery coach who's been a great addition to the team, supported by AmeriCorps, and when that funding runs out, scraping together some other funding. And he's acting as sort of a continuity link, meeting people in the hospital and maintaining phone follow-up after discharge. I've been having regular meetings with the DHMC hospitalists on a roughly quarterly basis, and most of this work has been on the medicine team, and I think that's where most of the patients are, but reached out to anesthesiology with grand rounds last fall, and we'll be doing surgical grand rounds, Luke and I, May 1st. And the BIT team does go to these non-medical services. We received a TDI incubator grant that's headed by Colleen Kershaw, and I'm on that project team along with others. And that's to improve care for patients with injection drug use and infections. So we can try to get patients on treatment and out of the hospital getting IV antibiotics through PICC lines, OPAT, home IV antibiotics. That project just started in early March and was quickly put on hold like much of everything else, and hopefully will come off the back burner in April. And these are how we've been doing on inpatient. There's, other than that dive in December, a fairly steady increase in number of patients at DHMC. In the emergency department, similar goals as inpatient, and they also have a peer recovery coach who's on site, which has been working a lot better than the previous model they had. There's been a lot of turnover and tumultuousness recently with the new medical director and new providers onboarding, but that is settling down and is reflected in the data. Hopefully things will be taking off in terms of new starts in the ED. And APD and Cheshire is active in initiating treatment, and APD is going to come on board shortly. Tricia Lanter has a grant from the CTN, which is comparing buprenorphine, a 1-week injectable form that's different than Sublocade, that's not available yet, versus a sublingual form, and looking at the impact of engagement in follow-up therapy. And these are the results. As I mentioned, we see things picking up just very recently after a slower start than was hoped due to turnover. And lastly, our waivered providers over the last 2 years have steadily been increasing. The next waiver course was scheduled for May 21st, which was going to be an ED-specific course, also appropriate for hospitalists, but a little unclear if that's going to happen at this point. So we will hopefully clarify that soon. And I'm all set if there's any questions or comments.
Charlie, why don't we hold the questions till the end? And anybody who has any, just type them in and send them to us. Thank you so much, Charlie. Our next presentation is on from Luke Archibald, who'll be speaking to us about Dartmouth's engagement in the New Hampshire doorway and a bit about the New Hampshire doorway generally.
Okay, can you hear me and see these slides?
We can. You sound like
Okay.
you're driving and PowerPointing at the same time, but.
So I'm going to speak briefly both about our addiction treatment program and the New Hampshire doorway. So we have several different treatment tracks on site at our ATP, and the doorway at Dartmouth is also located within our clinic, which is the branding of the state opioid response. We are the local doorway or hub for our region, which is really designed as an evaluation and facilitated referral service that provides ongoing recovery support as well as naloxone distribution. People can walk in during business hours or call 211 at any time to access the doorway. Statewide volume data is available online. In terms of our data last year, 2019, we saw 243 doorway evaluations, the majority of which were for opioid use disorder, though also a fair amount of alcohol use disorder. We distributed 66 Narcan kits directly to clients and provided 277 kits to community partners for distribution at their sites for a total of 343 Narcan kits. We're asked to collect data and submit anonymous data to the state for anyone receiving Narcan kits. So we have information on that, such as primary reason for opioid use or where people first obtained opioids when first using. And thanks to our data guy, Nick Salvis, for putting together these fancy slides. We're also managing the after-hours service. So when the doorways are closed, and the call comes into 211, our clinicians are fielding the after-hours call for the state. So we have some data there for volume to that service, as well as other information such as the substances that callers are identifying as problematic. But I wanted to slow down and talk a little bit about one pathway that I think the doorway has really been helpful in us improving the system. So traditionally, when someone was trying to access residential level of care, there's all kinds of difficulties in doing this. First is just, someone may be given a phone number and that's it, or they might not even know where to call. The applications can be complicated. Someone might be accepted, but a bed might not be immediately available. They don't have safe living environment. They might not have a phone that the treatment program can call them when that bed is available. And then even if they do gain acceptance to a residential program, for many, there's not a prescriber available that could start MAT for someone with opioid use disorder. And then after completion, even if they pass through all those hurdles, without ongoing support and treatment, they might be returning to their environment, which it might be a high risk for relapse. So I really think the doorway has helped navigate and improve the system. So first thing that we could do is after their evaluation, quickly do a medication evaluation to start buprenorphine if appropriate, for example, and then be the prescriber for that individual if they access residential treatment. The doorway and the grant funding made it possible to provide for respite or temporary shelter in a safe environment while awaiting acceptance. And then we have people that can help with this application obtain signed consents on our end and for various residential programs so that they can be in communication with the admissions department at one or more residential programs, see what the status is, get updates, and see if we can help with any of the pending needs in terms of that application, as well as provide transportation if necessary to the program. And then in some cases, there's been a delay from getting from the high-intensity program to the low-intensity residential program, maybe a couple days of not having the bed yet available, and again, provide respite housing for someone so they're not lost in that follow-up, as well as continue to be the prescriber for the buprenorphine as we're maintaining contact both with the residential facility and with the individual. And then when someone's plugged into after completion of the high intensity, now embarking on a low intensity program, say at head rest, now they're really in a good spot where they're getting additional assistance for progressing further in their recoveries, help with establishing employment, and then housing thereafter. So this has been, I think, a real improvement in the system. A couple notes on our addiction treatment program. We've been growing in all areas. In particular, our active buprenorphine list has been expanding. As of today, there are 350 people being actively prescribed buprenorphine products in our clinic. We also started last year offering more medication options, so extended release buprenorphine or Sublocade. We're about 6 months into offering that medication for people here. And so far, it's been very positively received. Most people find that they report that they greatly prefer getting the monthly injection, not having to worry about taking their medication daily, losing it. We don't have to be concerned about diversion risk and so on. And so far people seem to be, the majority of people seem to want to continue and are continuing it. We're doing this with about the equivalent of 1.5 doctors here. So kind of moving on to some COVID challenges that we're seeing. About a third or more of our physicians are telehealth only at this point for precautionary reasons. And we're really in this point of trying to transition any non-urgent visit to a telehealth visit, which is really a challenge when you have hundreds of visits scheduled in the clinic per week. The efficiency of those visits are reduced. Not everybody has the capability of setting up the telehealth visit or even a working telephone or active voicemail. And then we're constantly weighing for each of these visits what's so important that this person really needs to be seen in person, and we do need that toxicology for this visit. Other challenges really for our clinic, all of our groups programming is suspended at this point, so we cannot offer any of our IOP programming or groups in the MOMS program. In terms of the doorway, there's been some residential closures or not accepting new admissions, or have closed and then reopened, and so we're trying to stay up on the latest updates and get people into residential treatment if it's still indicated and needed. And then it's really thrown into question whether the doorway funding will continue after this first initial 2 years where there was optimism. Now there's a big question about whether this will be possible at the federal level to continue this project. I think we're saving questions to the end, so that's...
Yeah, I think we're going to. But thank you. You raised a number of questions, at least that I have, and I'm sure others will chime in as well. Thank you so much, Luke. Now we're going to hear from Daisy Goodman and Julie Frew talking about Moms in Recovery and the Center for Addiction Recovery in Pregnancy and Parenting. Daisy, oh, you already have your slides up, so I won't do a long introduction, but Daisy is a certified nurse midwife and doctor of nursing, and Julia Frew is a psychiatrist working together on this program. Thank you.
Hi, can everybody hear me okay?
Mm-hmm.
Okay, great. So I think most of the attendees to this meeting are already at least somewhat familiar with our treatment program, which serves about 70 pregnant and parenting women with substance use disorders, not just opioid use disorders. So I'm going to spend some time first talking about some of the clinical changes in our program specifically related to COVID-19, since as Dr. Archibald alluded to, we've been pretty strongly impacted by that. And then I'm going to pass the baton to Daisy to talk a little bit more about some of our research projects and work on helping to advise the development of a residential treatment program for pregnant and parenting women. Let's see if I can get my slides to go here into presenter view. There we go. So our program is a highly group-based program that I would say is really the opposite of social distancing in normal times. We have large numbers of women coming together on the same day of the week with their children. Their children were previously cared for by hospital volunteers, many of whom are elderly. And so it was very clear to us a couple of weeks ago that we were not going to be able to run our clinic with normal operations. So wanted to share with you some of the changes we've made and how we're sort of pivoting to try to take care of people. As Luke mentioned, we're not doing any group therapy sessions right now, and we've been touched to hear how much women have told us that they really miss that, and we hope that we're going to be able to develop some online resources to offer groups with the people they already know. We've converted almost all of our office visits to telehealth or telephone, again weighing, as Luke mentioned, the potential risks to someone in not receiving a sufficient level of care for their substance use disorder versus the potential risks of COVID exposure. We have a patient packet that our recovery coaches developed, which has clinic contact information, some great coping skills for times of isolation, and access to a lot of online recovery resources. We are still seeing some people in the clinic who have more severe unstable substance use disorder. This is largely people who would have been in our IOP or really who ought to be in residential treatment but can't access it right now. We're trying to get creative in working with our OB colleagues to collaborate on the care of our pregnant patients. So for example, if a woman is coming in person for an OB visit, such as for an ultrasound, we can often get her urine toxicology at that visit and spare her another trip to the clinic or to the hospital. We are still trying to see new evaluations in person, in part because of some of the 42 CFR Part 2 consents we need to have signed, and in part because the cases that we work with are really quite complex, with often a lot of acute child protection involvement. And we feel like in most cases, at least at the initial visit, getting that urine toxicology and meeting someone in person is optimal if it's possible. And then we can often do subsequent visits via telehealth. We have been exploring the possibility of having supportive family members assist with getting a urine drug screen if it's felt that that's necessary for someone's care but doesn't have to be done in the clinic. And then we are working hard to keep our teamness with all of our staff by having frequent team meetings via WebEx. So I wanted to share with you here on the next slide kind of what a sample treatment plan might look like for someone who otherwise would be receiving about 9 hours a week of group therapy via our IOP. So that woman might instead be having a visit in the clinic where she provides a UDS and sees either a doc or a clinician, a therapist from our program. She might have then another either telephone or telehealth visit with that clinician and with her MD later on in the week. We have our recovery coach and resource specialist working from home and checking in regularly with women in our program via phone or text. And then, as I mentioned earlier, we've provided a variety of online recovery supports. Our Center for Addiction Recovery in Pregnancy and Parenting remains operational with a Q&A line for outside providers, and we've been getting quite a few queries from OB providers and addiction providers seeking advice on managing people with substance use disorder without the usual range of resources they would have access to. So women who maybe otherwise would be in an IOP or a residential program, their treatment providers are looking for advice on managing those situations. So we are fielding those calls. And then we had hoped to announce to all of you that we have a really exciting conference coming up in June with Stephanie Covington, who developed a number of trauma-informed care resources, such as helping women recover. We are in the process of figuring out whether we will be able to hold that in person, whether it's worthwhile to hold it remotely, or whether we need to reschedule. So we will update this group as we sort that out. So I'm now going to hand off to Daisy for the next couple of slides.
Thanks. As Luke referred to already, there are many of our patients who come into the treatment program who really are eligible and should be offered residential level of care. And we haven't had the greatest luck from Moms in Recovery in getting people to sort of stick with the 28-day residential program. So our IOP patients, upwards over 75% of them actually qualify for ASAM level 3.5. So what has become abundantly clear to us is we have a kind of hole in, at the end of the treatment continuum for pregnant and parenting women with severe substance use disorders. So based on that, we did a needs assessment at the beginning of last year, thinking about what would a model of care look like that could allow us to I think the slides just disappeared, Julie. Oh, there you go. Thank you. That would allow us to serve this group of patients most effectively. And so what we were able to sort of brainstorm and bring together based on a lot of stakeholder input was a three-way collaboration between a new nonprofit, Families Flourish Northeast, which was recently registered as a New Hampshire nonprofit corporation. So the birth is complete and we're now in the very early postpartum stage. And then Twin Pines Housing to help us put together sort of the physical plan for that. And then with our program development guided by the Moms in Recovery clinical background and experience. And so our board of directors draws on the expertise of regional public health, Geisel, DH, and community members, especially members of the directly affected recovery community. We're working right now on a response to a recently released New Hampshire RGA, which we don't know if it will still be due at the time that it was originally intended. So currently, the due date for this proposal is April 15th, but we're really hoping that current events will allow an extension on that, since it's really hard to get into the site that we've identified to talk about sort of how much renovations will cost. So to wrap this part up, I think we're really moving towards this shared model, and we're really excited about it. Next slide. And then, of course, our perinatal SUD ongoing research projects are also heavily impacted by the current public health emergency. So the Moms in Recovery PCORI funded study has really been heavily impacted by restrictions on travel and limitations to external visitors at regional medical facilities, because this is a multi-site initiative. We're continuing with our clinical record abstraction, since fortunately some of those records are available electronically. So that's great and hasn't really slowed down at all. And we're intensifying the use of social media as a means for trying to push out recruitment. Julie and I are currently submitting IRB for a case series of perinatal exposure to alpha PHP, which is one of the ingredients commonly found in bath salts regionally. We have a poster accepted for an upcoming ASAM conference, which has now gone virtual, but fortunately the poster will be presented in recorded versions, so we may be able to share that. A recent BMC pregnancy and childbirth publication that was looking at factors contributing to resilience for perinatal women with OUD, and then we're currently looking for a funding source for a perinatal expert validation study. So we'll take questions later. Thank you.
And please do send in questions. I have many, but I'm not seeing a lot in the queue, so be delighted to get some. Thank you all for your work. The perinatal and OB group has always seemed to be way out front on these issues and always leading in innovation, so thank you so much. Sally is going to talk a bit about the DH Project ECHO.
Great. Well, hopefully many of you have heard about Project ECHO before this, and if you can go to the next slide. Project ECHO is a way of telementoring, telelearning that came out of the early 2000s from experience with the need for extending knowledge about treatment for hepatitis C. And the basic philosophy is that you move knowledge, not people. So the Project ECHOs are structured with subject matter experts. And as I mentioned, when this first started, it was related to treatment of hepatitis C, and those subject matter experts included the originator of Project ECHO, Dr. Sanjeev Arora at the University of New Mexico. And subject matter experts will get together and will interact with ECHO participants who could be primary care physicians, could be non-clinical staff, but people who are seeking guidance and learning from experts, and also have an opportunity to learn from each other. And the idea is that knowledge then is amplified in that all of the ECHO participants, which in the classic ECHO model are primary care physicians being connected to subject matter experts, those primary care physicians then are treating many, many, many patients. And they can indeed become somewhat of subject matter experts in their own community. So the concept is that knowledge is moved. You avoid the need to having to refer patients into very scarce expert resources, and that you establish a community of learning amongst the ECHO participants who develop a level of trust and camaraderie and community as they present cases and learn from each other. Next slide, please. We have had a number of people here at Dartmouth-Hitchcock go out and be trained at the University of New Mexico. And then we came back and we initiated our own Dartmouth-Hitchcock ECHO program, starting with our very first program, which was on mental health and substance use behavioral health for primary care providers. And you can see here the planning committee and the subjects that were addressed in course 1. And we are now also providing a course 2 of that, the behavioral health for primary care physicians. You can see on the top picture, those are the group of experts that get together in a room over at one of the administrative buildings at Dartmouth-Hitchcock. And then the participants join using Zoom technology, which is exactly the same Zoom technology we're using today. And we talk about everyone participating as a Hollywood square, just like we are today. The people generally are getting together about for a session that lasts generally 1 hour, that can be hosted once a month or every other week. We tend to host those every other week just to keep the momentum going. And the format is highly stylized. It's 10 to 15 minutes of a short didactic in which Charlie or Matt or Seddon or one of the experts would share a best practice or new evidence or a new medication that's come onto the market, something new or important knowledge that that expert felt was critical to be shared amongst a larger audience. And then the bulk of the hour is spent discussing a case. And one of the participants will present that case. The cases are all scrubbed, so there's no protected health information shared. And then through the course of the case discussion, there'll be discussion back and forth with the participants, discussion amongst the experts, and discussion amongst everyone participating. And it really turns into an extremely rich learning environment. Next slide, please. You can see here a list of our ECHO courses. I predict that there will be further disruption and changes in this calendar as we all deal with COVID. But I'd like to call out that there's one there in yellow, COVID-19, and we have at least one, actually 2 different ECHO sessions that will be starting either right now. I think one started either today or tomorrow, and then in a couple of weeks. And we are using our ECHO infrastructure to rapidly just disseminate knowledge and education about COVID-19. We won't have a lot of cases to discuss. Thank God we don't have a lot of cases to discuss yet, but the idea is that we wanted to get out ahead of the clinical surge that is coming, and to do our best to prepare our communities for this screening for identifying and treating this disease. Next slide. This just gives you an example of the number of participants that have either completed courses on the left or who are currently actively participating in active courses on the right. And these numbers, you'll see 37, 26, 15, 30. These are numbers of the Hollywood Squares that sign up to participate with the ECHO course. We are anticipating that with the COVID courses, we may have 50, 100. I believe Dr. Kerrigan was on a session that had about 150 participants related to COVID-19. So I think the model will be a little bit less back and forth and a little bit more didactic for the upcoming COVID-19 sessions. But the beauty of this is that you can, you can add lots more people at no cost. And we are offering our courses for free. We are working with an employer-based course. This is a course that's targeting employers in our region, with the focus being on how do you support employees who have mental health or substance use disorders. And we are using a sponsorship model for that, asking for donations from employers to participate. But otherwise, the courses are all offered free of charge and largely supported either by Dartmouth-Hitchcock operational dollars or grant funds. Next slide, please. And just go click, click, click. You'll have 3 different things. We do a pre-post evaluation. We can't measure the application of the knowledge, but we do ask people to self-reflect and tell us how their confidence changes in response to the course of instruction that they pass through. I think this second bullet of 100% felt a decreased sense of isolation. And I would say in the days, in the weeks ahead, I think it will be even more important for us to reach out and make sure our professional colleagues across the region feel that they have a place, a community where they can go and they can reflect on the cases that they're caring for and receive input from experts. So I'm really, I think this is a really important measurable benefit of the Project ECHO courses. And then the final bullet, we ask people if they're interested in attending future courses, and there is usually overwhelming sense of enthusiasm that they would like to participate again. And I believe that's if you go to the next slide, we are here, we're open for business. Our biggest constraints are the number of facilitators and project managers to put the courses together, but I can't tell you how proud I am of this team that has been able to pivot in just a matter of 1 week, 2 weeks to present a number of different COVID-focused sessions that are coming up, and we'll be marketing widely through our communities. So please look for those future courses.
Thank you so much, Sally. It seems so timely that this started just this past year, and here we are in a time when we need to do all this distant learning. So thank you for leading that. We are going to be hearing next from David de Geisel, who is an infectious disease doc at Dartmouth-Hitchcock, and who has been a harm reduction advocate, and who has some webinars that we have linked to on the SUMHI website on COVID and SUD. They're really excellent, so I wanted to recommend those, and thank you, David, for that. And Aurora Drew, who is a public health researcher at the Dartmouth Institute on health policy and clinical practice.
Hi, everyone. Thanks for the introduction.
Yes.
Well, I can't do better than Seddon. I am who Seddon says I am, so here I am. And I'm gonna let Aurora actually kick off the presentation, and then I'll reappear a little bit further on.
Great. Hi, everybody. Just as methods multidisciplinary institutional research study with 2 phases. In the community, we don't call this discern, we call it the rural health study, because we have learned that most of our population is not interested in engaging in a study that has surveillance in its name. And so the first phase of the study is an epidemiology study with the primary aim to characterize the risk, policy, and service environment in 11 rural counties in Massachusetts and Vermont and New Hampshire for people who use opioid or inject any drug. And the second phase, which we are launching this summer on the beginning of August, pandemic permitting, we have delayed start by a couple of months because of COVID-19. Is a randomized control trial of hepatitis A plan versus enhanced usual care. Concern about COVID is that enhanced usual care may be telemedicine by the time we get out into the field in August. That'll be interesting. So this project was responsive to a NIDA RFA a few years ago for HIV, HCV, and related comorbidities in rural communities affected by opioid injection drug epidemics, and was a reaction to the rural HIV outbreak that occurred in Scott County, Indiana. So represent our study locations for the first phase of the project, and on the left you see our many collaborators. This is really a large collaborative effort between states and multiple institutions. And I also will note that this study uses several community engagement methods to enhance the project and continuously put stakeholders and people with lived experience. And it's one of the things most enjoyed about this project. So I'm going to talk briefly about phase 1 and then turn it over to David to talk about. So phase 1, we wrapped up our data collection in 2019, and there were all these yellow starred sites, more participants in Vermont than in New Hampshire, and then just 1 county in Massachusetts, so we had 82 participants in Massachusetts. We did do respondent-driven sampling for recruitment in each of these communities, and there are some social network going right now. I'm actually not going to present results for them yet. They are ongoing right now. We also did, it's a mixed method study, so we did 53 in-depth interviews across the region in Vermont, New Hampshire, and Massachusetts. We interviewed both stakeholders, which included police, local harm reduction authorities, care providers, and a range of other folks, as well as people with lived experience, so people who are using drugs, primarily people with IV drug use, either currently or in their history. We also conducted a policy and legal scan, which I'm not going to talk about at all today, but we did publish a paper on it, and I can show you the paper if you like. So I'm going to just talk really briefly about our phase 1 lessons, which were several rural New Hampshire counties are at really high risk for Scott County-like outbreaks. Syringe sharing and HCV are highly prevalent. In New Hampshire, we saw, 66% of our participants had a positive HCV rapid test. And then in New Hampshire, there was also a lot of shared injection equipment, 65% reporting sharing injection equipment. We also identified really important service gaps, particularly in those that led to our phase 2 plan. There's a challenge with access to clean syringes, phlebotomy services, HCV testing and treatment are also limited, especially in New Hampshire and Vermont. So this is the cascade of care we saw, and this is limited to people who reported using IV drugs, which is, and test positive for hepatitis C. So this is about 306 people in our study. And you can see that that very few of them actually make it as far as taking or finishing hepatitis C medication. All right, and I'm going to pass it over to David to talk about phase 2.
All right, so based on those results, we decided that what we wanted to address was access to hepatitis C care and access to harm reduction. And to do that in a trial setting, we wanted to compare standard of care to an intervention that would make it easier for folks to both get harm reduction syringe injection supplies and harm reduction service in general, and to get access to hepatitis C care. So our intervention proposal is that we want to look at mobile telemedicine, and I'll tell you a little bit about what that is. For the integrated treatment with community partners. And we were going to compare that to usual care, although we're planning on enhancing that a little bit in the sense that we give folks who get randomized to the usual care arm a care navigator who will help them make appointments and keep appointments at one of the hepatitis C providers around the states. So what does the telemedicine look like? Well, we are purchasing a van similar to the one that you see there, and we will park that van outside of community partner locations, and that's mostly syringe programs, soup kitchens, so folks, places where there's a very low threshold for folks who use drugs to seek care or engage in community services, harm reduction services. And we will invite them into the van to then get screened, and on the next slide I'll show you a little bit more about that process. And then the proposal is that we will screen and treat people there on the van, and the provider who does the treatment will never be in the van, but will be visible on a screen in the van. So that's the mobile part speaking to the van, and the telemedicine part speaking to the provider not being in the van, but in a remote location and engaging through telemedicine. And then another very exciting part that we added on to the study is that we're validating the collection of blood on dried blood spots cards, as you can see down there. Think of heel pricks in newborns for newborn screening. Similar technology, and people elsewhere have shown that you can actually get a viral load from those. So we're doing that with the New Hampshire Public Health Lab, which would be big because it could cut down on one of the steps in the Hep C diagnostic cascade. Aurora, could you advance this slide? Thank you so much. So a little bit more about the study design. It's going to be a randomized trial. We're hoping to enroll 220 people. The intervention, as I said, is telemedicine care onto a mobile van. The control group gets referred to providers around the states. And everybody gets, in a non-randomized fashion and not in a trial fashion, therefore, gets harm reduction services, including injection equipment, Hep C testing, and Hep A and Hep B vaccination. We're going to do that in the counties that you saw on one of the first slides that Aurora showed, where we did our first part of this study. And we're aiming to re-enroll folks that were part of the first study and that tested positive for Hep C, or that who would like to be re-screened. And we're hoping to get referrals from our local partners and clients. Next slide, please. Oop, that's it already. And then here's our big research team, multiple sites, lots of people involved. Aurora mentioned it already. So we've been talking about COVID, of course, and how it impacts us. As of now, we're planning on just holding out. So we're optimistic that in the summer, we can go live and can be in the communities in a safe way. But we're also aware that that might have to change or might not happen. So, but for now, we're staying the course. That's what we have.
Okay, thank you so much. We did have a number of questions come in, and some of them are being answered in the sidebar, and you can probably see that, but I think it would be nice to have some discussion as well. So let me just say, Will, you had a question, I think, for Julian and Daisy. And did you want to ask that? Do you want to unmute and ask them about their publication?
I was just interested in the resiliency factors and just what
Yeah, well, thank you. So this was a study, we had collected qualitative data with interviews with postpartum women who were, had continued in treatment after, after delivery up to 1 postpartum year. So there was a range of durations from when the delivery had occurred to when the interview occurred. And we were able to really learn from their testimony that they really relied on a combination of resources from everything from their internal motivation that was related to pregnancy and parenting, all the way through access to insurance and sort of like external high-level structural factors. And then in between that was, you know, informed providers who were non-judgmental, program availability, et cetera. So they really endorsed what we already know, that it's really supports on all levels that allow women, and peer support was also very highlighted by the group. So it really allowed us to sort of document and demonstrate from women's own words how important the structures and frameworks that we're setting up are. So I'm happy to share that, but it was exciting to see that emerge from the data with a good qualitative analysis.
Yeah, that's reinforcing for what you've been working on too. Sounds like the things that you're trying to do. So,
yeah, thanks. I'll just post the link here.
I wanted to tag on a question to you also, Daisy or Julia. The model that you're creating with co-residing children, is that something that's been piloted previously, or are you really working this out from ground level?
So in the 1990s, there were a number of demonstration projects that were funded by SAMHSA. Unfortunately, most of them folded, but Horizons for Women at UNC is a sort of stellar gold standard program that is now entering you know, what is this? Its 30th year now.
Wow.
I think it was launched in 1990. So they have wonderful outcomes. We actually have a relationship with them where they've agreed to serve as consultants for us. We're working on that MOU right now with DH Legal and Families Flourish Northeast, this new entity. So it is a model that I think will be very interesting to study the implementation of in a rural and remote rural community. So we're excited to do it here. And I think that will be the innovative part, is launching it somewhere not at UNC, but in an area where we're really rural community and serving lots of women coming from very rural communities.
Great, wonderful, thank you. Phil, you had a question, Phil Barbato, you had a question for Luke and one for Charlie. I think part of that's been answered, but you want to ask them?
Yes, so thank you. Luke had responded to the one, and that was in regards to how do we submit a referral to the doorway. Oftentimes we have a number of patients who are waiting for a residential treatment bed to become available, you know, needing to discharge from the hospital because they're medically ready to do so, and you know, looking to try to fill that gap before they can get into a program. And Luke answered that question, mentioning submitting a referral to the addiction treatment program, calling 211, and making sure that I was aware that that is for New Hampshire residents only, which thank you, Luke. My other question was for Charlie in regarding to you. We have a number of patients who are prescribed that and needing to get into a short-term rehab, a physical rehab stay before going home, but oftentimes facilities aren't taking that. In fact, I had a case today where the patient was declined even though their PCP was willing to continue to prescribe that. And I was just wondering if there's any ways around that, if there's anything that we can do or contact that can be made to the facility to just help the patients out and advocate for them.
Yeah, we addressed this about a year and a half ago, and I guess up here it felt like it was less of an issue because there was kind of a mutual dislike. Our patients didn't want to go to rehabs either, so it became a bit of a moot point. And it usually needs to be negotiated on a case-by-case basis. But I think trying to address the stigma head on, and which was a big part of our work at the beginning on the inpatient service, like a lot of our own nurses in the hospital and so on were reluctant to give buprenorphine and so on. And I think they've quickly learned that buprenorphine quickly quiet downs a lot of the addictive behaviors, which is what leads to the stigma and the reluctance to take on patients. So once they see that happen a few times, so a good example can help. But And I mean, on the OPAT project, we've had a similar thing talking the OPAT and visiting nurses into feeling comfortable treating these patients, and that's gotten better. But I think it just takes that individual negotiation with each site.
Gotcha. Thank you.
Good. Ryan Fowler, you had a question that generated a lot of responses around bath salts. So it might be interesting for people to talk a little more about that. So do you want to voice that?
Yeah, sure. So thank you. I'm Brian. I'm the harm reduction coordinator for the Claremont Exchange, the needle exchange program in Claremont. And very different work out here than in Manchester, Nashua, or the Seacoast, mainly because of the weird synthetics that have emerged as the primary drug that's available. I know that there's some people in town that order it from coolchems.com and get it out into the streets that way. That site was recently shut down because of COVID, and so I'm curious what trends will look like going forward with the cheap synthetics stimulants that are available. I will just add that, you know, anytime I've talked to somebody who's using these stimulants, they say that they would absolutely love an agonist therapy like Ritalin or Adderall or Vyvanse or Concerta in lieu of these synthetic cathinones. So if anybody out there is sympathetic to stimulant use disorder and stimulant dependence, consider looking at stimulants the same way that we use Suboxone. So yeah, I'm curious what people are seeing with trends in cathinones, because they're scary, they're dangerous, and they're hard to deal with. So I'm curious, like, when I'm engaging with somebody who's in some sort of mild psychosis, what compound am I working with? I can work with people on various compounds, but these are just kind of a mixed bag. So I was happy to see that there's surveillance being done with the alpha PHP in pregnant women. So I was curious if there's other sets of information out there as far as which specific compounds are in the community.
I think this is a really difficult area right now because we just don't have that much published, and our testing is often behind the substances that are out there on the street. And when I talk to patients, you know, they don't know what they're using, and sometimes it's that there were bath salts mixed with their methamphetamine. Sometimes it's that there was methamphetamine mixed with their bath salts, or fentanyl mixed with anything. So, you know, we're trying to understand the best we can based on the testing we have, but even the alpha PHP and the Udalone, which we picked up recently, are considered out of scope results. They're not part of the standard panel. So your guess is as good as mine often as to what people are using. I think that, you know, we're hoping to publish on this a little bit going forward, because we do feel like we're starting to develop a little bit of a clinical understanding of what this looks like, both during times of intoxication and during times of withdrawal. You know, the only literature I think we have to guide us around the potential for stimulant treatment would be the methamphetamine literature. I'm not aware of anything right now published on treatment of synthetic cathinone use disorder with something like Vyvanse or other prescribed stimulants.
Thank you, Julie. Anybody else want to comment on bath salts, their treatment, what we're seeing in the streets? One of the things that's come up in a number of meetings I've been in recently is the potential effect on COVID changing the patterns of drug use due to supply lines being disrupted. I think Molly Rosignol brought that up at another meeting based on a comment from somebody on the Seacoast. Has anyone been seeing any changes in pattern?
Hi, Joe Hannon here. I was we were doing syringe exchange. Carrie and I were in Manchester on Sunday. Was that yesterday? I can't even tell. And you know, we had quite a few participants that came out in the rain, and you know, I had several people I asked about you know, drugs, and they said it's hard to get everything except for drugs right now. But that doesn't mean the supply won't be a problem in the future. So I've been having a lot of discussions with people about how we're going to deal with this, and there's no real good answer, because the way that people usually get their money or get their drugs, their supply, not just the supply of drugs, but how they get their money, whether it's panhandling, shoplifting, sex work, just your average everyday street hustle. All those opportunities are drying up. The stores are closed. People aren't, you know, getting close to people. So there's not just going to be a potential shortage of supply. Although I do have faith in the dealers. They're gonna do their best to meet demand. If anyone's gonna do it, I mean, we can't get respirators, but they will get drugs. But prices will go up because it'll be harder to get them in. It'll be a little difficult. So people will be more opportunistic, I believe. And this is just my own personal expectations. People will do what they can get. So you may have people that are switching back and forth. And we've seen that over the last couple of years. We've seen some people that go back and forth between meth and heroin, depending on what's available locally. It hasn't been a big problem for shortage. I mean, there's plenty of drugs out there, but I do worry about how they're going to get it and what they're going to get. So we are worried about increased risk of overdose, not just because of all the other stress factors that are involved with this, but increased isolation will lead to more deaths. So we're still encouraging people to maintain social distance, but not be alone. Obviously, this is not something you should do alone, but you shouldn't be on top of someone else. And we've been giving out handouts from the Harm Reduction Coalition. National had a handout for safer drug use during COVID-19. And it talks about some of those things. And I think it's, people have been receptive to it, even though as soon as they leave hearing that, I see a bunch of high fives and hugs in the distance. But most people are taking our advice, I think, pretty seriously.
Thank you, Joe. I see Joe Harding had a question. Joe, would you like to jump on with your question? You have to unmute.
Sorry, I was having a hard time doing that. Can you hear me?
Yes, that's fine. Thank you. Joe
So
from
I'm just wondering
DHHS.
for any of the providers, whether MAT or behavioral health services that provide outpatient or intensive outpatient or even residential, offering those types of services in lieu of residential services that aren't readily available, or even peer recovery supports. Are any of your providers offering those services via Zoom? That could be individual sessions or even a group session.
Thank you, Joe. I have that question too, because I know many centers across the state are offering groups by Zoom and other platforms. And I was wondering what is the challenge in DH offering those services now? Julie or Luke?
My understanding is that right now there's a question out to find out whether the normal billing codes that we use for group therapy are not billable via telehealth, and whether we can gain permission to offer those as an unbilled service. So I think that's where things stand right now. We're hoping that we will be able to offer them going forward.
Do you have a timeline for that? Guess?
As soon as we hear back about permission, we hopefully would be able to do it.
Good, great. Okay. Jim Potter, you had a comment, or Janet Potter, I'm sorry. I know Jim Potter too. And you'll need to unmute to ask the question.
Oh, okay. I didn't have a question. It was just a comment, probably for the people who are much smarter in this call than I am, about ketamine. I worked for years in the ERs in Springfield, Vermont and Brattleboro, Vermont. And there was a lot of bath salts came through there pretty early on. And they utilized ketamine because they were utilizing the Haldol and Ativan combo did not work for those people. So they were utilizing ketamine. So I think that says something, and that worked. I think that says something about the chemical makeup of the drug that ketamine works. So a lot of your ambulance drivers and police officers could give you this information of what works to bring acute psychosis down in people with bath salts intoxication. The only other thing I was going to say is I'm just working as a provider, not so much now. I'm in a high school giving lots of, and middle school giving lots of education and prevention, but I think one of the mistakes we made with naloxone was thinking that people had a magic bullet. And I think us as providers, we need to tell people naloxone was made for heroin overdoses. It was not made for fentanyl overdoses or carfentanil overdoses. And I think it is our responsibility as providers to give people that information, because I have heard anecdotally from people, and I'm sure you guys have as well, if you counsel addicts in recovery, people have died because they thought they had a life-saving drug and they needed several doses of that medication, especially in a rural area, to get them stabilized. Does that make sense?
Yeah, I think people have, EMS has been trying and others to get the word out there, and I'm sure syringe service programs, Joe, you or Carrie could probably comment on this, have been trying to educate people that with fentanyl on the street, several doses of traditional naloxone may be needed. Does somebody else want to comment on that?
It's Carrie. There is definitely instances and different supplies that come through that need a large number of doses, like we've heard up to 8 or 9. But that seems to have really decreased. So part of the messaging should really be around using a smaller amount, especially with new supplies. And that's a lot of the messaging we give to people who use drugs right now, knowing that the drug supply is rapidly changing in light of COVID. But there, as far as I'm aware, and this comes from the National Harm Reduction Coalition, Narcan-resistant narcotics are not have not been proven. So in those cases, many times it's that maybe 2 doses were insufficient, or that other help was needed. But I'm not aware of a clear connection to full resistance to naloxone. It needs more doses.
Thank you, Carrie. We're almost at time. I would like to just spend 1 minute or maybe 2 minutes having Bridget Aliaga, who works with our Community Health Partnership, just give an update of what's happening with outreach to the community, which I think is really important at this time. So Bridget, could you just say a few words for us, please?
Hi, everyone. I'll just give you a really super quick update so you can all get headed out. But all of our community health improvement work has really shifted to support Upper Valley Strong, which is a group of organizations that come together when there's an emergency or a crisis in our communities. So the last time the group was activated was back in 2011 for Hurricane Irene. And so this past March, they were reactivated for the COVID-19 pandemic. And then within this Upper Valley Strong umbrella, there's about 20 organizations and a lot of different people helping to respond to the needs in the community. So the purpose of the group is really to connect folks to services, connect organizations to the needs that they have, coordinate the resources we have in the area, and also to share expertise. And so the group has really identified a couple of different priorities. So childcare, housing, support for seniors, food access, transportation, and volunteer coordination. And so within all of those subcommittees, there's a ton of people you probably know, and we're really trying to identify what the needs are locally. And I believe there's a Greater Sullivan group also gearing up to have this similar Upper Valley Strong group in their area. And so the last thing I'll say is that both of our public health networks also have links that are meant for organizations to take and for us to really identify what those needs are. And so we're working in collaboration with them as well. So if you have any questions, I would encourage you to reach out to Reggie Cooper. She is the project manager for that, but feel free to reach out to me as well. Happy to connect you to whoever you need to connect to within those subgroups.
Thank you so much, Bridget, and thanks for doing it so timely. And I think that's really a reflection of public health networks across the state. So whatever region people are in, they can reach out and find ways to get involved through projects like Upper Valley Strong and the Public Health Network. So thank you all very much. Thank you for coming. Thank you for great questions, great discussion. And we'll all take deep breaths and see what the next few weeks hold for ourselves and for the people we serve. Stay healthy, everyone.
And thanks so much. And also, it's an incredible group of people doing important work. And thank you all for getting together so we can all understand what's going on. Really shocked. It's just kind of mind-blowing how much has developed over the last few years. So thank you.
It is. Come a long way. Thank you all so much.
Thanks, everybody.
Have good evenings.